clinical scenario is a 23-year-old man who is diagnosed with acute myeloid leukemia, where it's confirmed with the flow cytometry showing immunophenotype consistent with acute myeloid leukemia.
Okay, so I request Dr. Bagal to comment on this. This is the case of the hematological malignancy, 23-year-old man. So first, when it comes to you, can you put your reviews on that?
Yeah. So thank you for this opportunity to participate in this discussion. I think really interesting and need of time to discuss these niche areas even in oncology community. I deal with hematological malignancy. So a 23-year male who is post-pubertal and has a diagnosis of acute myeloid leukemia. So first of all, one point I'd like to put forth is not all hematological malignancies are the same. Or for that example, not all acute myeloid leukemias would be same. And the disease course may vary from patient to patient. So whenever we are faced with such situation, we try and dissect out what are the patient who have emergency and they need immediate treatment. So this patient typically would be patient with hyperleukocytosis, patient with coagulopathies, patient with severe cytopenias, or someone having a mediastinal mass with impending respiratory or cardiovascular compromise. In such cases, their treatment needs to be started, and unfortunately, in certain situations, we may not have time for discussing or trying fertility preservation in such patient.
Yes.
But in most of the patient, we will have time and we will also have a window of opportunity to deal in such situation. So definitely in other patients, we discuss fertility impact of this thing.
Yes. Yeah. Sorry. You were saying something.
No, I think I
Yeah.
can take
Okay. Yeah. Thank you for your insight. So, suppose we assume that we have little bit time, and he is now 23 years. So, I request Dr. Tribheva sir to comment on that, like how we go about for the fertility preservation in this particularly young man who has got this hematological malignancy.
Yeah, good. So I need to know whether this man is married or not.
So this man is married, yes.
Yeah, so he is sexually active.
Yes.
He's a sexually active married man. Does he have any children
No,
at
no,
present?
no.
No. Okay. So this is an active man, married, but he has no children. So he is having semen for sure. And talking to him about producing semen samples is not going to be an embarrassing situation.
Yes.
We have to explain to him, and as doctor has mentioned, that we have time, some time, although there is an urgent need to start, but we have enough time to ask the young man to give us enough samples over a period of 10 to 12 days so that they can be frozen. And with the newer techniques of cryopreservation by vitrification, we are able to have a very, very good post-thaw sperm count and motility. That is one thing. So that kind of counseling has to be done. Secondly, we have to not just presume that the wife is okay. We have to make sure that the wife is also evaluated before we advise the man to undergo any kind of therapy for cryopreservation. And like in any other infertility patient, the general examination, systemic examination, and history taking is very important. So we cannot just take it for granted that there will be nothing in the history that will need attention and that nothing will be there in the clinical evaluation that will need attention. So all that has to be done, and then he is advised to give a semen sample. If the native sample is found to be good, very highly motile sperms, good concentration, then it can be frozen as it is. But if it is found to be a little subnormal, then maybe it can be processed and concentrated and then stored to be used later. Now, if his therapy is started, should I go on with that, or then we can say
So
that
we can discuss about the options basically.
Yeah. So the first option is semen cryopreservation by vitrification. Second is, in case he has difficulty in collecting a sample because now he's been diagnosed with cancer, although he may otherwise have been able to give a sample, then he may need a little help from the center by providing a vibrator or some kind of TV and some movies to be shown, which will help him to get a good erection and ejaculation. If we find that his semen is azoospermic, if he is an azoospermic man because he has not proven his fertility yet, then we have to go for other alternatives, and that I can talk now, or you want to bring that up later?
Yes, sir. We will take the next case for the surgical
Okay,
extraction.
Okay, so I won't talk on that. So
Yes.
that is one thing. Now, secondly, we have to tell him that even after everything is done, the pregnancy rate is around 20 to 30% with frozen sperm, which are where the native sample is good. And if at all the native sample is not very good but subnormal, even then he can go for IVF ET at a later stage where the success rate can be as high as 50% per cycle with the frozen sperms. So that is one thing. And of course, you have to talk about the method which is going to be undertaken. If it's just cryopreservation and thawing and insemination at a later stage, then the cost is going to be very, very low. But if it is going to be IVF ET, then that has to be discussed at an earlier stage before going any further. If he turns out to be azoospermic, and later on you're going to talk about sperm extraction, microdissection, and extraction. But at this stage itself, if we find that he is azoospermic, or if he is severely oligospermic, I would subject him to microdeletion studies. Because if my Y microdeletion study confirms that he has a particular kind of deletion, then even if he is subjected later on to sperm extraction, then the chances of finding sperms are very minimal or nil in certain cases of Y deletion. So that study should be done before he is advised to go for deletions, extractions, sperm extractions. I'll leave that to you to bring it up at whenever you think it's convenient, relevant.
Yes, sir. Yes, sir. That is absolutely true. That this was very important point that we need to go for the Y microdeletion studies if initially before going for the invasive options. So definitely the first preference would be the sperm cryopreservation. If not, then we can go for the surgical options that we will discuss in detail in the next case. But yes, this is one important point, as Dr. Bagal also rightly said. We need to, each case is different, so we need to assess the time. That definitely important coordination with the oncologist. But this is very important that even though there is a significant emotional stress and difficulty, it is very important to discuss this at the point of the diagnosis. And as sir also rightly said, that we need to discuss all the factors, what will be the costs involved, what are the further things, even the counseling of the spouse, wife, as well as the families, and then later on what options do we have, and we need to discuss in all these aspects. Thank you, sir. Yes, sir. Yes, sir. Yes, sir.
Yeah, discussion with the family. Before entering into discussion with the family, the couple has to be taken into confidence whether they want to disclose this to the family or not.
Yes, yes.
There are pros and cons of it.
Yes.
Because they may be wanting and the family may oppose. But the pro is that if they need any financial support and the family knows, the family may pitch in for that. So, the couple has to decide whether the family should be informed about this.
Yes, sir. Yes, sir. Because it's individual right, definitely, sir.